welcome back to our second session today at our third Wave Psychotherapy online conference. I'm joined here with our second speaker, Professor Michaela Swales, who's going to give a talk on Dialectical Behaviour Therapy. So Professor Swales is a Consultant Clinical Psychologist and Reader in Clinical Psychology at Bangor University. From 1994 to 1995, she trained in DBT with Marsha Linehan in Seattle, and for 20 years ran a clinical program for suicidal young people in an inpatient service. After completing special supervision in DBT, she became one of the founding members of the UK DBT training team in 1997 and director of the training team in 2002. She has trained more than 1,000 professionals in the approach, seeding over 400 programs, both in the UK and further afield. She is the co-author of Dialectical Behaviour Therapy, Distinctive Features, which had its second edition published by Routledge in 2016, and Changing Behaviour in DBT, which was published by Guildford in 2015. You can learn more about our work at www.dbt-training.co.uk. So let's give Professor Swales a warm welcome and let's get started.
Thanks very much, Niall. It's very good to join you here. And I'm just impressed at all of you folk giving up your weekend to learn about third wave therapies. That really gladdens my heart in these difficult times that we're all facing. So before we get going, I just wanted to just put up my conflicts of interest. It's important just that you know that before I start, so that I receive consultation payments for my work in DBT, royalties from books in DBT. I'm receiving payment for this presentation today. And also my husband is involved in running a DBT training company. And it's just important that you know those things before we get started. What I'm going to do in my presentation today is I'm going to talk to you a little bit about what we know about the evidence for DBT, and then really explore what its fundamentals are, its theoretical foundations, what we understand about the primary problem for clients who come to this treatment. I'm then going to give you a flavour of what the treatment looks like, and also talk to you about how some of the things that we would do during treatment and show a little video clip about that. Now, I know that the audience today is a mixed one, so there'll be some people here who are mental health professionals who are interested in doing some CPD or kind of broadening their knowledge of different perspectives. There will be people who are not in the mental health field and are just interested in hearing more about these sorts of developments. And there may be people here who have suffered from some of the problems that these treatments are designed to help, and you're all very welcome. I do want to say at times during the presentation I will be talking about suicidal and self-harming behaviours. And I know that this can be a challenge, especially as many of us have experienced these things at first hand. And I do hope that the way in which I talk about them won't create any challenges or difficulties for you. My apologies if it does. And do feel free just to step away or take a moment before coming back to the presentation if there are any challenges. My sincere apologies if that does happen. I hope it won't, but I did just want to mention it before we begin. So let's start first of all by thinking about DBT as an efficacious and an effective treatment. And so some of you might not be familiar with that sort of distinction, but it's simply to say that whenever we're developing a new treatment, we want to think about how it works in sort of the best conditions, almost like in laboratory conditions. We've been hearing a lot lately about the trials testing the virus for COVID-19, and what they are testing is its efficacy. How does it work under the tightest controlled conditions? And then we want to know, well, what does it work? How does it work in the real world? How effective is it when it's delivered under ordinary circumstances? Now, when you're using a vaccine, there's some fairly standard procedures that you have to use, which doesn't really matter whether you're in a laboratory sort of setting or if you're in the real world. Although we have heard things about some of these these vaccines having to be held at very low temperatures, which perhaps presents a challenge for delivery in the real world. If you're thinking about a psychological treatment, often it's even harder to get it to translate out into the real world, because often in setting up clinical trials for psychological treatments, sometimes the clients who come for those treatments are perhaps not as severe or as complex as some of the clients who might be seen in routine mental health services, particularly in public mental health services. So it's important to assess whether a treatment is both efficacious, like does it work under the best possible conditions, but is it also effective in routine conditions? Well, the good news about DBT is that it's effective in both circumstances. It was the first evidence-based treatment for personality disorder back in 1991. And in fact, in that way, it sort of really changed the field, because up until that point, it had often been thought and said, and in fact, it saddened me a great deal to still hear that in some places people feel that individuals who end up with this label of personality disorder are untreatable. And this is absolutely not the case. Is that DBT was the first treatment to show that it could help people who have that label, but there have been other treatments since which also have been shown to be efficacious and effective. So it was the first treatment to show that it could actually help people with this diagnosis. But also, it is now the most researched. It's the most researched treatment in the field. Now, something's gone rather odd here with the slide colouring, so you can't really see that. But there are now over 30 research trials on this treatment published, and it is now very well established as a solid treatment. And also, these treatment trials have been done in different places around the world, and also by different teams. Because, of course, sometimes if you're the treatment developer and you're passionate about a treatment, then you may well get better outcomes because of your passion. So it's also important to make sure that treatment can be done by other people who have not worked with the treatment developer and who can learn the treatment and do it in other contexts. It also, as I said, transports effectively to routine practice. So there have now been lots of studies which have looked at the treatment when it's delivered in NHS settings, public health settings, other sorts of settings around the world, and it shows very similar outcomes. Now, there are variabilities in outcomes in routine practice, and some of those to do with the things that happen when you try to move a treatment into routine practice. That's not really the target of today's talk, but there are some things often public services often want to sacrifice some of the integrity of psychological interventions in terms of being able to fully deliver them, because often, certainly with something like DBT, it's quite an intense intervention, as you'll see. And so some of the variation is due to that process. But generally speaking, it does transport very effectively and show similar outcomes in routine practice as it does in these clinical trials. It's a manualized treatment, and this is one of the things that really helps to make sure that it can be used outside of the places where it was first developed. You can see here on the screen a kind of photo of the treatment manual, Cognitive Behavioural Treatment of Borderline Personality Disorder. This was published in 1993, and there's a little story about why it's not called Dialectical Behaviour Therapy for borderline personality disorder. And that was simply because Marsha Linehan's publisher, at the time Marsha Linehan was an unknown academic, and the publisher said no one's going to know what the word dialectical means. And they wouldn't let it be on the title of her book. So it's perhaps the only treatment manual of a successful treatment which isn't actually named after the treatment contained within it. So there's the treatment manual, which outlines the comprehensive treatment and all its different elements. And then in addition, we've got the skills training manuals, which are both the most recent versions are also there on the screen. And these describe what happens in one element of the treatment, which is a skills training group component. And I'll say a bit more about that later. What's important just to note here is that in essence, there are kind of almost two treatments in one here. That for clients with personality disorder difficulties, so very severe complex problems, especially those who have suicidal or self-harm issues, you really need the comprehensive treatment, which includes, and you would need both sets of manuals here for that. However, there's also some recent research showing that for clients with less complex and less not necessarily less severe, but less complex and multiple diagnoses, the skills training element, sort of a comprehensive skills training group approach, as evidenced in the skills training manuals, can also be really helpful. So there's kind of two treatments in one here. in DBT. It's also been adapted for other populations, in particular for suicidal adolescents, but there are also adaptations for people in forensic settings, for children, for clients who have a primary eating disorder or primary substance use disorder. So it has been adapted for other populations, although the evidence base for those is much smaller and still needs development. As a result of its efficacy and its effectiveness, it often appears in national guidance and recommendations. In the UK, here it appears in the NICE recommendations for treatment and management of borderline personality disorder. And also the Cochrane collaboration regularly summarises the outcomes of clinical trials for different populations, and the most recent one actually in just a few months ago in 2020 again demonstrated that DBT, as well as being the most researched treatment for this population, also has very solid outcomes for clients. So given that it's got some evidence that it's useful, then it's perhaps worth thinking about, what is its essence? What are the sort of core elements of it? And so I wanted to say a little bit about how the treatment conceptualizes the problem for clients who have this diagnosis of borderline personality disorder. And what DBT really focuses on is the thing that we see here in the center, emotion dysregulation. And it sees this as being the primary problem that clients who come to this treatment have. That they experience emotions more intensely than other people. They probably have even more intense emotions than others. They're often more sensitive, and I'll say more about that in just a moment. But also, because of just the way that their system is designed, that it takes longer for their emotions to come back to baseline. And if you are someone who has that those sets of problems of emotional sensitivity, reactivity, and a difficulty in your emotions coming back to baseline, that then ricochets out, we might say, into other areas of your life. And I mean, this is true for all of us. If we just think of, perhaps some of the emotions that we've been experiencing very recently, maybe some of you on this call have had to change your plans because of the lockdown that was announced yesterday, and so your emotions are heightened for understandable reasons, and often then other things follow for any of us, so that if we're emotionally dysregulated, often our interpersonal relationships don't go so well. And for clients with these sorts of issues, often they have a lot of interpersonal chaos and often a lot of fears of abandonment. And I have to say, having worked with a lot of people, young people over my career, that comes really from their experience of abandonment early on in their life, and that often they have been abandoned, and sometimes because some people find their emotional intensity and the levels of distress they experience hard to manage. Of course, it's much harder for the person to manage them, but nonetheless, that's often an issue. So often interpersonal difficulties are a common concomitant of emotion dysregulation. Of course, if your relationships are not going well, that of course impacts again on your emotion dysregulation. So you get that cycle going. It's also the case, if we go to the other diametrically opposite quadrant, if you're struggling with your emotions, then also your thinking tends to be dysregulated also. And so often for clients with extreme levels of emotion dysregulation, they may experience paranoid thinking, and also they may dissociate and find it, become completely disconnected with what's happening. And also as a result, if you're someone who's chaotic, your relationships are in chaos, your thinking is disturbed, then it's hard to regulate your sense of self and to see yourself as a person who is kind of steady across time and space. If you today are talking to someone and you feel that they understand you and that they are kind of in your corner, but maybe something else happens tomorrow, something that they said or some other thing that comes to light, and you feel intensely emotionally distressed, and now you really don't trust this person and you wonder how on earth you ever did trust them. If you have that kind of oscillation in your emotions and your relationships, it's hard to kind of feel steady in your own sense of self. And so often that's a common problem, and clients not knowing what it is that they want or how to achieve what they want. And then also we see there that a common consequence of extreme emotion dysregulation are suicidal behaviours, non-suicidal self-injury and impulsive behaviours. And these behaviours are sometimes we could think of them as just a natural outworking of extreme dysregulation. You may have found yourself at a time, if you've been extremely dysregulated, that you may have become more impulsive. But also these behaviours are extremely good at re-regulating emotion. And in fact, if it wasn't for the negative longer-term consequences of them, you could even be in favour of them, because they're so effective at rapidly changing inner emotional states and regulating emotions. And I think it's really important just to really try and or land on that point for a moment and really kind of absorb that. Because I think often clients who have these sorts of difficulties, often in mental health services or even by people in the public domain, they often tend to be thought of as manipulative or somehow that they're doing these behaviours for attention. I mean, I have to say, as if there's something wrong with having attention. There's nothing wrong with wanting attention or needing attention. Most of us do want and need attention. It's perfectly normal human function. However, it's often talked about as though somehow this behaviour is attention-seeking and manipulative. And one of the things that's really important to appreciate is that these behaviours, that's often not the function of them. Their function is often not about what happens in the environment. For many people, these behaviours are very private, and for many people, they would prefer them to remain private. It's just unfortunately that they often then realise that they've done something and that they need help. But the primary reason for these behaviours is that they regulate emotion. And if you talk to clients who engage in these behaviours, that's what they tell us. And so if you're working with someone with these sorts of difficulties, it's really important to bear that in mind, not get distracted by the fact that there may be things that happen in the environment. And those things may be relevant as well. They become secondary reinforcers, as we would say. But it's really important to stay focused on this central function of affect regulation. And you'll see how it is that the treatment addresses that as we go through our talk today. So, DBT is essentially a treatment for this emotional dysregulation, and it's worth just kind of pausing for a moment to maybe think, some of you might be thinking, well, where does this come from? How is it that people might have these sorts of problems? Well, when DBT was first developed, there was very little known about this, in fact, and Marsha Linehan, the treatment developer, had a hypothesis about what might be going on based on some limited evidence at the time. And interestingly, her theory at that time, biosocial theory, has come to be supported increasingly by evidence in the last 20 or so years. And so what she talked about was that, first of all, for people who end up with these problems, they often are biologically vulnerable. And their vulnerability is this sort of reactivity and sensitivity to emotional stimuli. And that this is perhaps, and we now know, is underpinned by some genetic factors. Also, early experience, even in utero, when the child is in the womb, that things that can happen during that period can make a child more sensitive and have a biologically more sensitive system. And also early trauma or early difficulties in a child's life affect the developing neurobiological system to make the child more sensitive and more reactive to emotional stimuli. So there's a strong biological basis to these problems. However, in addition to that, we know also that people who end up with these problems have been raised in environments that have been less than ideal. That often these environments have not been able to support or validate the child's emotional sensitivity in the way that would be maximally helpful. So often, this isn't helped by cultural factors. There may be people from lots of different cultural backgrounds on the call. I sincerely hope they are, and I'm always interested to hear how these things are different in different cultures and different contexts. But one of the things that can happen is if you have a very sensitive child, it requires even more attuned and sensitive and invested parenting. And that's not always possible for parents to be able to offer often parents themselves might be struggling with these very same issues. There may also be a lack of support in the context. And so what happens is that the developing child, doesn't get the necessary supports that they need to be able to manage this very sensitive emotional system that they have. And so often what happens then is that they engage in behaviours which for children are perfectly natural outworking of being very emotionally distressed. They may have temper tantrums, they may be somewhat aggressive, or they may be very withdrawn. And this, of course, then often leads to further what we would call invalidation from the environment, or criticism from the environment about the child's temperament or development. And these things over time transact to lead to an increased sense of emotional vulnerability and difficulty in managing emotions. We also know that a high proportion of people who end up with this label of borderline personality disorder also have a history of trauma, of emotional abuse and neglect, physical abuse, sexual abuse. And so those environments are the most extreme forms of invalidation, which would, of course, naturally lead to extreme, intense emotions. And also, this process of being invalidated is that, often it goes for many years before that sort of abuse is uncovered, and the child is not their emotional response is not being understood, and they're kind of being pathologized when in fact they're in an intolerable situation and just doing the best that they can. And so there are lots of things that we know about early development and in childhood and then further into adolescence, which will lead to the development of these problems, and really have solidified this idea that Linehan developed about emotion dysregulation being at the heart of these problems. So how does DBT go about trying to address them? Well, DBT is an integrative treatment, so it drew from a number of different traditions in order to sort of become a thing, if you like. And it started actually as a behavioural treatment that Marsha Linehan, who developed the treatment, she was actually a behaviourist, and that was what she really set out to develop. She set out to develop a behavioural treatment to help people who were suicidal and self-harming. And that was where she began. And so she really focused, and there's still a strong element in this treatment of focusing on behaviour and behaviour change. She drew on the three key sort of pillars of behavioural treatment from Skinner in terms of operant conditioning, Pavlov in terms of classical conditioning, and Albert Bandura in terms of social learning theory. And this is a radical behaviourist treatment, much like other third wave treatments, like ACT is another radical behaviourist treatment, where what you're really thinking about is that anything that a person does, not just their overt behaviour, I'm standing up now and I'm gesticulating, that most people would recognise that as a behaviour. I'm speaking to you, I'm presenting to you. But also, as I'm doing that, I'm having emotions and thoughts, and I'm being aware of sensations. But those emotions and thoughts that I'm having are also behaviours. And one of the things that's helpful to think about these things as behaviours is it means that the theories developed by Skinner, Pavlov, Bandura can be used to both think about changing our emotions and thoughts as well as our overt behaviours. So DBT really it's got this strong focus on changing behaviour, and I think that'll become evident as we go through. But what I wanted to say is that what Marsha Linehan discovered when she set off to apply behaviourism to clients with personality disorder who had suicidal and self-harming behaviour, she found that actually it was just completely impossible, that the treatment just kind of blew up. Yeah. And one of the things that she was aware of as she was watching the therapy that she was doing, she always recorded her therapy and had people watching her as she was doing it, was that what seemed to be the trouble was that the relentless focus on change, especially when the person in front of you coming for treatment has got multiple problems, lots and lots of problems. If you're constantly pushing for change on all of these things, it actually leaves the person sort of feeling hopeless, overwhelmed, and also as if nothing about them is right, that sort of it's them that's the problem. And so this relentless focus on change she realized a problem. And so what she went searching for was something to counterbalance that, something to really go opposite to that. And just because of her own personal experience, she's written her own memoir about how she applied these principles in her own life. She went to Zen Mindfulness. Zen Mindfulness is the complete opposite in many senses to behaviorism. Rather than focusing on change, it talks about comprehensive acceptance of things as they are. It's a not change approach. Now, interestingly, in that sort of complete contrast to behaviorism, there are some similarities. For example, if you were to move into a Zen monastery, for example, you wouldn't get told a list of rules and regulations beforehand. You would just you would learn how to do things by your encounter with the contingencies, by your encounter with the environment and how people respond to you. And so in that sense, it's kind of some similarities with behaviorism, but kind of conceptually, it's very different. It's kind of the antithesis, one might say. And so there's a real focus in DBT on comprehensive, radical acceptance of the client as he or she is in the current moment, of the current situation in which they are in, the state of the therapy relationship, and the present moment. And a DBT therapist needs to be able to fully embrace that side of things. Now, I thought, as I've been talking at you for half an hour, now might be a moment to have a bit of a mindful practice. And so I'm actually just going to do that with you just for a few moments, just as we might do in a skills class or when working with a client. And so what I'd like you to do is I'm going to ring the bell just to signal the beginning of the practice. And as I ring the bell, I'll ring it 3 times. Just settle yourself in, just breathe, just notice where you are. If you're sitting, just notice your contact with the chair. Now, in DBT, one of the things we're wanting to work on is to be mindful in everyday life. And so what I really would like you to do is to keep your eyes open, if you can, while we do this practice. But what I'd like you to do is to just rest your eyes on something that's not too sort of challenging or stimulating to you. And as you do that, as the bells come to the end, what I'd like you to do is to just focus your attention on sound. It might be sound within your own body. It might be sound in the room you're in. It might be out with the room that you're in. And to just simply notice any sounds that you observe. Now, the chances are, as you do that your mind might wander off. It's in the nature of minds to do this. They're kind of like a little bit like puppies, that they gambol off after the latest leaf, or as my dog does. I'm just hoping he doesn't see a squirrel in the garden, because then there'll be lots of dog barking, for which I apologise in advance. But our minds can be a little bit like my dog seeing the squirrel. They just kind of go after it. And so if you notice that, just simply notice that and try and bring your attention back to sound. If it goes again, just notice and bring your attention back to sound. Okay. So I'm not going to go for too long, only be a couple of minutes. So just simply be here and just notice whatever sounds you hear. Now, of course, if we were in a room together, I would ask you what you noticed. And maybe some of you might want to say in the Q&A later. But what I'm going to say is a little bit about what typically can happen, although, of course, we're all unique and different things are likely to have happened to different people, depending on your current state, your experience with mindfulness and many other factors. Some of you will have noticed that your mind went running off. Yeah. For some of you, it may well have gone at the start of the practice and you were actually only even aware that it had gone when I rang the bell to finish. And just sometimes that happens, something happens and off our mind goes and it's hard to come back. And that's one of the things we're working on in the treatment, is to try and help our clients to learn to be able to call their mind when their mind has gone, to call it, bring it back, and know, oh, it's gone, and to call it and bring it back. Some of you might have noticed that whenever you heard things, but like my dog barking there, you might have dog barking, bird calling, heater buzzing, that you might have noticed yourself labeling sounds as you heard them. Now, this is a very interesting thing. Of course, it's a skill that we're taught since we're really tiny to get good at. And we'll have got praise for it when we were really tiny, for labeling sounds and labeling things. But of course, this isn't actually especially mindful. It's very useful as a human to get you through the world, but it's not especially mindful. And sometimes it can lead you off into different sort of thought trains. So one of the things when we're listening to sounds is that we're wanting to really just see if we can observe the sound, So if I would, rather than saying dog barking, I would maybe just go, well, I heard a rah, rah sound, would be a more description of what I heard. So one of the things, if you are new to this and you notice yourself labeling lots of sounds, is to see if you can just simply try and notice the sound itself without labeling. This is incredibly hard. Some of you might have noticed that your mind went wandering off, and then you might have had a judgment. Oh, I shouldn't be doing that. I'm meant to be concentrating. And you might have had some emotions kind of come up about that. And so again, that's very interesting, that our minds sort of instantly kind of compare us and judge ourselves if we somehow are not doing what we should do. And of course, that often leads to emotion dysregulation. And so again, this is one of the things in the treatment we're really wanting to encourage our clients to notice, is simply just to notice, my mind has wandered, and to let go of any judgments about that, and to let go of any self-criticism about that, but simply to notice, my mind wandered. How about that? Interesting. Never mind. Bring it back. Because there are so many things that happen in life which can lead us to be judgmental about our performance and self-critical. And often the clients who come to this treatment have had that a lot in their upbringing, that we're really trying to cultivate the capacity to non-judgmentally become aware of our mind and our emotions and our actions. And so DBT, as well as having a strong push for change, has a big push for change. It also has a strong focus on simply noticing and being present, which came from Marsha Linehan's study of Zen Mindfulness. And indeed, she herself was a sort of, she was strong in both. She was a professor at a university with a specialism in behaviorism, but she was also a Zen Roshi. So she was a Zen teacher. So she also progressed as a Zen teacher also. And those two strong elements are really there in the treatment. Now, these are two very contradictory approaches. Yeah. And one of the things that Linehan appreciated is that she needed something to try and, as it were, house them in a kind of coherent way so that they weren't going to be tearing each other apart. And that's where dialectics comes in. And so I'm going to say a little bit about how dialectics is relevant to the treatment. It is fair to say that often my adolescent clients used to refer to it as diabolical behaviour therapy rather than dialectical behaviour therapy, and there's definitely some truth in that. It's not the easiest treatment in the world to do. It does demand a lot of the therapist, and it's hard work for the client, definitely. However, we'll focus a bit more on its dialectical nature rather than the challenging aspects of it. But what really dialectics is about is it recognises the validity really in contrasting perspectives on reality. Now, we see in this little graphic here, we've got two opposing teams here who are kind of in a tug of war. Now, they're all looking very cheerful about it. But often the aim in a tug of war is really to kind of pull until one side ends up on their backside, usually on a muddy ground. Yeah? And that's really a non-dialectical approach. Yeah? A tug of war is non-dialectical. And what Marsha didn't want to happen was to have behaviorism and Zen mindfulness pull each other apart in this treatment. What she wanted to do was to find a way of bringing them together. You might say in a way of finding the middle path between these two things. And the way you would do that is, in the way you work dialectically, is first of all to respect and value the different perspectives that come from contrasting views. So that in the treatment itself, of course, it values what behaviorism brings and it values what Zen mindfulness brings, and recognizes that these two things are seeing the world from slightly different perspectives and both have value. And that idea really permeates the treatment. So, for example, if you and your client have a disagreement about how to do something, so perhaps my client really feels absolutely desperate and they feel that their only solution is that they want to go into the hospital to escape the situation in which they are in. And they are really advocating for that. I, on the other hand, might remember the other times they've been in the hospital and remember how that's been really unhelpful and caused them even more pain and difficulty and led to all sorts of other consequences which were really undesired. Now, what could happen here is that my client and I, we could fall out over this. We could end up having it with me just trying to convince my client that going into the hospital isn't the solution. They have to work harder to manage themselves. And my client going harder to try and persuade me that really I don't get how desperate they are and that this going into the hospital is the only solution. Whereas a DBT therapist recognizes that there is a validity in what the client is saying, is that they are desperate, they have nothing else to give, they are overwhelmed and exhausted. That is the truth. And the truth I hold is that going into the hospital, whilst may provide temporary relief, also leads to other problems which have caused further distress, exhaustion and difficulty. So both of us have a perspective on the truth. Both of us have got the truth on our side, if you like. Dialectically, what we have to do is we have to find solutions that respect the validity in both of our perspectives. So I think it's really important here that it's not a compromise, yeah? So it's not like a Brexit deal where you're trying to kind of, get one over and kind of get a deal, by knocking off different people's perspectives, yeah? What you're after is a synthesis, which is where you actually say that actually the perspective of the other side, different to your own, has truth and validity. And that doesn't mean that you don't have truth and validity too. So we're looking for solutions that respect both sides. So in my client, for example, we might look for solutions that, for example, it could be that going into the hospital could be a solution. However, we'd have to think about how to mitigate the problems from going into the hospital. So perhaps my client might go in for a shorter period, or it might be for a specific intervention. Or it could be that we find a solution where my client gets a break from where they're living and the circumstances, but not in the hospital, but somewhere else. And we'd have to work out that solution. So working out syntheses that respect these different sides is not easy because you have to really embrace what's valid in both perspectives. But often in that endeavour, and you have to do it with a kind of an honesty, that you really do believe that. It's not just something you're saying, that you really do believe that your client has got a huge element of the truth. And you might have some perspective that is partly true too, that you can find genuine syntheses, or the middle path, as we might say. The other thing about a dialectical worldview is that it really embraces this idea of everything being very connected. Now, this used to be a bit of a hard sell, but I have to say, living in a global pandemic, everybody's totally up with the idea that we're all connected. And something that someone can do further away can impact how we kind of work. And so that in a dialectical perspective, we're always being awake to the fact that what I do as the therapist will be impacting the client, what the client is doing is impacting me, what's happening in my team, what happens in our culture. These things are all connected and they reciprocally influence one another. And we're open to that. And so that means that whenever we're trying to analyze a problem, we're always willing to search for what's left out in our understanding. What have we missed in our understanding of this problem? What has been forgotten in how we're conceptualizing what's happened? So that's an essential component of dialectics. And also that as well as being connected, that the world is full of opposites. That if you argue strongly for, we see this again in the whole Brexit thing, or indeed in the global pandemic, the kind of the tension between public health versus the economy. There are these tensions that kind of come up. And one of the things in a DBT perspective, in a DBT worldview, you're wanting these multiple perspectives because you're wanting to benefit from the value and the truth and the different perspectives. And that it is through these kind of opposites and the fact that everything is connected that that change is continual and transactional, and that as a result of that, things change. In terms of this, the opposites and the sort of dialectical worldview, my identity as a presenter right here, right now, is based on the fundamental assumption that there are people online on this call actually listening to what I say. I can just see the chat thing bumping a little bit in the corner, so I'm reassured that there are people out there listening to me. But of course, if there weren't, I'd just be some kind of slightly odd middle-aged woman talking to herself in her study on a Sunday afternoon. My identity as a presenter is entirely based on the fact that there's people there listening. Yeah. And so this idea of kind of connectivity, reciprocity, and these tensions that evolve in the environment, these are what lead to a continuous transactional state of change. And as a DBT therapist, you're wanting to be awake to that. You're wanting to make sure that you don't get stuck on one end of a dialectic and being very kind of rigid about how you're conceptualizing a problem. You're wanting to be able to move to different positions and different perspectives in order to find a way to move forward smoothly for your client. Okay. So DBT is a team-based treatment. I'll just say a few things about this and then we'll take a little 5-minute break. So DBT requires a team of therapists in order to deliver it. And so this is one of the things that makes it different to some other therapies, is that it's not something that a single therapist can do in a room with another client. It really is about a community of therapists working with a community of clients. And so that's really important to kind of know if you're going to set up a DBT team, but also if you're someone thinking about getting DBT, you want to be sure that you're getting your treatment from a team. One of the reasons for this is that as a dialectical treatment, you need multiple perspectives and multiple different views, and you can only get that from a team. And so the DBT team, its task is to consult to the DBT therapist and provide him or her with different perspectives and different views about how to be the best therapist they can possibly be for their client. The other reason you have a team is that often clients that DBT treats have a lot of severe problems and high risk. And this can lead to therapists potentially burning out if they don't get the right amount of support. And so that's another reason for having a team, to make sure that you're kind of getting the sort of nourishment that you need from your team in order to be able to stay resilient and to be able to deliver the treatment. So I'm just going to say briefly how the treatment program is structured. And this is when you're delivering for clients who have complex problems, which can often be termed personality disorder. So it has 4 elements, the treatment. It has, as you might expect, it has an individual therapy component, but it also has a skills class component. So the client will have an hour a week individual therapy, but they'll also come to a 2.5-hour weekly skills class. And it's in that skills class that they would receive the curriculum in those skills training manuals. And the idea is that the skills trainers are kind of pumping new skills into the client in the skills class. And then the individual therapist, when they're analysing the problems the clients had this week, they go fishing for the things that the skills trainer has sort of planted in the client to see if they can draw those out and then really help the client think about how to apply those skills to their particular problems. And you need both of these elements. Is that learning new skills is very challenging. If any of you've tried to learn a language or to do anything, it takes a lot of time and practice to learn a new skill. And learning to manage your emotions and your thoughts and your relationships is no easier than learning a foreign language. It's just as difficult. And so you therefore need your individual therapist whose task it is to help you really apply what you're learning in the skills class to the unique situation that you have. In addition to that, DBT also has an element called telephone coaching, or it can be also via email and via text. But this is where the individual therapist, outside of standard therapy hours, would be willing to take a call from the client for coaching about how to actually apply the skills in a problem that's happening right now. And so DBT therapists are willing to take calls outside of hours to be able to coach clients. Now, these are not crisis calls, they are skills coaching calls. And they're remarkably effective. And also the data show that DBT therapists don't get any more calls from their clients than people who do other sorts of therapy. But the nature of the calls is different. They are more about skills coaching and less about crises. So these are the three elements that the client is in receipt of. And then, as we mentioned, the therapists themselves, they are in receipt of being in a consultation team. And the task of the team is to support them in delivering these other elements to the client. And this comprehensive DBT that you see here, represented by these four elements, is the one for which there is the most evidence for clients with complex problems. So, we've got a treatment program. What do we do as a DBT therapist? Well, we target problems in a hierarchical manner. So we're going to list the problems that the client has in a sort of predetermined order, and that's decided by the treatment. And this helps you as a DBT therapist to not be overwhelmed by the number of different problems and to help you decide which problem to tackle at any one time. And so I'm just going to show you a couple of examples here of some fictitious patients, but they are very similar to clients that I've treated over the years. So on the left, we've got Jane, and what you see for both of them here is that we start with life-threatening behaviours. In DBT, these are defined in a specific way. So these are suicidal behaviours, non-suicidal self-injury, or serious aggressive acts. You can see here with Jane and Robert, slightly different things that they are battling themselves, but those are the behaviours that you see right at the top. And the rationale for this is that if your client dies or kills someone else, they are going to be out of treatment and you're not going to be able to help them. And so you're going to have that as your top priority. Your top priority is to keep your client alive in order to be able to help them. The next thing is that for clients with this level of complexity, the next biggest risk after death is that they might drop out of treatment and then not get a treatment that otherwise might help them. So we're really going to focus on behaviours that get in the way of them getting the therapy to its maximum benefit. Now, some of this might be things like not attending regularly, a very common problem, as we see there. It's both relevant to Jane and Robert. It might be that they don't practice the solutions that you come up with in therapy. As we say there with Jane, or maybe your client just really says and does things in therapy that are really difficult, like telling you to F off and isn't really listening to what you're saying. But after those life-threatening and therapy-interfering behaviours, the next thing you're going to tackle is what are called in DBT quality of life interfering behaviours. Now, this isn't the best term, I have to say, and I know Marsha herself realised that it wasn't the best term, because quality of life might imply, for us right now, it would be being able to see our families at Christmas, perhaps, or being able to, change our job or even have a job at the moment. But what we're focusing on here in DBT are behaviours associated with other psychiatric diagnoses. So we see that here for Robert and Jane with vomiting, binging, social anxiety, substance abuse, but also other seriously destabilising behaviours. So we see there with Robert property damage and fighting with peers. These are things that are really going to destabilise his life, and so we really want to focus on those. And so when your client comes into treatment, you're going to work with them on getting a list of these behaviours that you're going to focus on in a hierarchical way. You'll start on the things at the top to begin with, and as those start to improve, you'll move your way down to address the other things. Now, it's worth saying that at this point, some of you might be thinking, but why on earth would anyone want to go into a treatment where you're going to do that? Many of you might have been with clients who've just refused to do that kind of thing. And I think this is really important, that that DBT really centres on the central factor, that it's not a suicide prevention or a self-harm treatment. It's a life worth living development program. And so when you start with someone in DBT, you really have to try and understand, what would a life worth living be for them? That DBT strongly holds this position that people who are trying to kill themselves or who are harming themselves, they are doing so because their life is not worth living. And that our task is to help them build a life worth living. And so before getting into all of these things that you have to change, you have to really connect with what is it that your client would find. What if they weren't doing all of these things, if they didn't have all of these problems, what would a life worth living be like for them? Because that's what we're having to work towards. So that it's not just focused on eliminating problems, it's actually focused on eliminating these problems in order to develop a life worth living for our clients. And that's really kind of a central feature, and something a DBT therapist will be constantly going back to, that the reason we're working on stopping this self-harm is because you told me that you wanted to get married and have a family, and all of your relationships have ended over the extent of your self-harm, which is why we're really wanting this to stop. So there's a constant linking of solving these problems to a life that the client wants. Now, of course, often a client might lose hope or even not have any hope at all that they could get that life. And that's your task as the therapist, is to hold that hope and the belief that this can be done and that you will help them to do it. And so alongside this, work on decreasing problems, we're also working on building up new skills, new strategies in order to be able to build a life worth living. So once we've got our goals and we know what the client wants and we've got our target hierarchy, well, what are we going to do? Well, we treat the highest priority behaviour first. So what we're going to be doing each week, our clients track their behaviours on a diary card, and we select the behaviour from the diary card that comes highest in that list of targets. And we're going to analyse the behaviour, and we're looking for what we call controlling variables. So these are emotions, thoughts, and actions that determine whether or not the behaviour is going to occur again. So some of these might be things that happen before the behaviour. So, for example, it might be an emotion that when the client experiences shame, they almost always go on to harm themselves. It might be something that follows the behaviour. Perhaps it's that after the behaviour they feel intense relief, or that all the stress has just gone. I was talking to a former client of mine earlier this week who was saying, it was just, she just had a sense of tension across her chest, and the only thing that would take that away was harming herself. It was the only thing to begin with that gave her any relief from that. And so the relief coming from the behaviour was one of the controlling variables. It kind of is keeping the behaviour going. So we're constantly looking, as we analyse these behaviours each week, for skills deficits, so things that the client doesn't know how to do. So, for example, how to manage shame, or how to get rid of this tension across the chest, or whatever. Or perhaps it's persistent thoughts that they're no good, or they're hopeless, or they're disgusting, or whatever it is. So we're looking for skills deficits, and we're going to teach skills in order to kind of help the client overcome those. But we're also going to be on the lookout for emotions and thoughts that might get in the way of trying new skills or developing new skills, or problematic things that happen in the environment that mean that the client won't practice their new skills. So, for example, if the client is practicing interpersonal skills and the people in their environment just punish them for that, then of course they'll stop using them. So we're going to have to problem solve how to actually get the new skills working effectively in the client's environment. And we're going to systematically solve these problems by both teaching new skills, but also using other strategies from the cognitive behavioral therapy canon, if you like, cognitive restructuring, exposure, and contingency management. And so DBT draws on all of those cognitive behavioral treatments. In that sense, the original title of the book, Cognitive Behavioral Treatment, wasn't so far off, because that is an element of, strong element of the treatment. A DBT therapist needs to be a really good, solid cognitive behavioral therapist, as well as effective at mindfulness and being able to be dialectical. And so we're going to systematically solve these problems. Here's just a couple of examples from my hypothetical clients. So this is a situation where the client avoids going to a party. She has social anxiety. She gets a text from some of her friends because she doesn't like to acknowledge her social anxiety. She hadn't said that she wasn't going to go. And she gets a text saying, "Where are you?" She feels really anxious about that. And then she starts thinking, "I should go. I really should go. I'm a bad person that I don't go." And so then she experiences shame. And the shame is what's really intolerable to her. And so she takes an overdose of tablets, and her shame and anxiety go down. So here the controlling variables would probably definitely be some anxiety, also the shame and the thoughts, "I should go." And so we'd be focusing our treatment plan around those particular elements. Here's an example from Robert. He comes to therapy hungover. He asks his therapist asks him for his diary card. He hasn't done it. He feels a bit of shame about that. He thinks, "I should have done it." But then he thinks, "She shouldn't make me do it. She knows how hard things are for me." And he feels really angry. And that's when he tells her to F off. She backs off, seeing how difficult things are. And she validates him about, obviously, things are really difficult. And then his anger and his shame go down. So here, some of the controlling variables are likely to be the shame and the thoughts that "I should have done it," and the anger. But also the fact that the therapist backs off is also likely to be a controlling variable. And to get this behavior to shift, we're going to have to both help Robert manage his emotional side of things, and also help the therapist to be able to stay in the game and be able to handle this more effectively. Okay, so I wanted to show you a little video clip about how we might go about rehearsing new skills for a client in this situation. So in this particular clip I'm going to show you, this is from an unscripted role play that I did with a colleague of mine. And what's happened for this client, this is actually a full session, so I'm only going to show you 5 minutes because that's all we have time for. But what's happened, and the client has been telling the therapist that she harmed herself over the weekend. And what had prompted this was that she'd been feeling quite lonely, and she drank some alcohol, which is a problem for her. But she then decided to go and visit her ex-partner. And she'd gone to visit him, and she'd knocked on the door, and he had refused to let her in. They have history for when she's drunk before, and he refused to let her in. And she banged on the door, tried to get let in, and he wouldn't let her. So she went back home, and she just felt overwhelmed with lots of emotions, and also just felt like she couldn't stand it. "I can't stand it," she says to the therapist. And so now there were lots of things that we worked on in this session. And to solve this problem, you need lots of different things. But I'm just going to show you a little clip where actually we do a little bit of work on being mindful and being mindful of our thoughts. So let me just I can't stand it. Yeah. But might be possible just to stand there and just breathe.
It comes automatically. It's
Absolutely.
Not like I think it myself.
No, I know. And that's one of the tasks that we've got in moments of very high emotion. It's like we become fused with our thinking and our thoughts become sort of facts almost, yeah? So the question is, it's about learning to kind of try and pull ourselves apart in those moments, but that's difficult. It's a hard skill to learn. You know, a couple of things come to my mind is you might not be able to do anything about the first time it comes to my mind. I can't stand it, yeah. But it might be possible just to stand there and just breathe and think, you know, I'm having the thought that I can't stand it. The thought that I can't stand it is in my mind. Yeah? Do you think you could try that?
I could give it a go.
Right. Okay. Just imagine for me now, let's just rehearse it a little bit in our mind,
Okay.
yeah? Because you're quite good at getting pictures in your mind.
Yeah,
You can, yeah. So if you could just, is it easier for you to do it with your eyes closed, your eyes open, to get a picture of yourself standing just in front of your door?
I can see myself.
Right, okay. Well, I
don't
want
even have to close my eyes.
Yeah.
I can, it's like it's burned.
It's
in my
right there.
brain.
Now, if I'd been right there with you, if I'd happened to just sort of materialise right next to you, what would I have seen as you had just come in there?
Come in the door. What, like on my face?
Yeah, or in your body. I mean, were you kind of, you know, hunched over? Were you, I don't know. I'm just wondering what picture I would have seen.
Yeah, probably tense and frowning.
Yeah, okay.
I think that probably.
Okay, all right. So I want you to imagine yourself back there. Yeah? Okay, and you're having that thought, I can't stand it. Okay. And what I just want you to practice with me is just saying to yourself, I'm just noticing the thought, I can't stand it in my mind right now. I'm just noticing the thought. And as you say that, I want you to try and let go of the tension, because you've even got the tension right here, right now, can you? Just see if you can let go of the tension. I'm just noticing the thought that I can't stand it.
I'm just noticing the thought that I can't stand it.
Yeah. I'm just noticing the thought.
I'm just noticing the thought that I can't stand it.
Okay. Now what I want you to try, just what happened right then? What thought went through your mind?
It's like,
I can't do it. Yeah. Okay. So we can do a couple, because I was actually thinking myself, as I was imagining myself in your situation, I was thinking a couple of that, I can't, you know, I'm just noticing thought, I can't stand it, might just still me for a moment. But then I think what we needed to move to was something a bit more validating, a bit more like, this is really difficult, this is a very painful situation for me, this is a hard thing for me to have to deal with, something like that. Because it is very hard. And I think one of the things that you said was that, in a sense, the cutting kind of demonstrated to you how hard it was, so we kind of need to have some other way. Yeah? Okay, so can you just imagine sort of like, I'm just noticing the thought, I can't stand it, but then this is a very hard situation.
that might be better.
Let's try that then for me. Just try that. Just imagine yourself standing there saying, this is very hard for me.
Okay. Just noticing the thought, I can't stand it. It's very hard. It's very hard.
Yeah.
It is hard.
It is difficult, yeah. Now tell me, what did that feel like?
That was a bit easier.
That was a bit easier. Okay. Yeah. So what we noticed here, a few things in this little tiny clip that are kind of quintessentially DBTs. First of all, you know, this is a point partway through the session, about a bit more than halfway through, and the client has got a notepad and she's writing, because we're going to be, you know, I'm wanting the client to practice these things. We've generated a few things already, and now we're on to another thing, and I'm wanting the client to practice, and so she needs to be able to remember. Now, in these days of video therapy and smartphones, I often will get my clients to video me rehearsing some of the things with them. And that's the other thing, and this is a behavioral treatment. So although what we're practicing here is a mindfulness skill, noticing the thought. I'm just noticing my thoughts. Can I just notice my thoughts rather than getting caught in them? We're going to do behavioral rehearsal, because what we need to do is practice. And then also what we saw here is when you get your client to practice in front of you, you notice there's a problem. You notice that something about this isn't going to quite work. And so you then have to finesse it and try something else to see if you will get that to work. And so there's just a little snippet. Solving this problem required lots of different things, but it gives you a little bit of a flavour of the kind of the workmanlike sort of strategies, and also the attention to behavioural rehearsal. And so one of the things we're really going to do in the treatment is to enhance skills. And we saw a little bit there of mindfulness. But there are some other elements that we're going to do too. But I'll just say a little bit more about the skills class. It's 2.5 hours each week. It has 2 class leaders, the leader and the co-leader. The leader's doing most of the teaching. The co-leader is watching for the process and seeing what's happening and trying to really help validate and see dialectical positions in order to keep the class going well and on track. It is run like a class, we have PowerPoints and we have whiteboards, and of course we run them all on Zoom now, and they seem to work just as well on Zoom or other platforms. I should say other online platforms are available, I guess. The target hierarchy differs in a skills class. So in a skills class, we only would tackle anything that was therapy destroying, like if someone was, shouting and screaming or something of that kind, which very rarely happens. Mostly what we're focusing on is teaching new skills. And we manage therapy interfering behavior rather than treat it, so that, lots of things happen in skills class. People might, kind of play on their phone, or they might kind of fall asleep, or they might not be very engaged. But those things we'd manage them, but the co-leader might do a little intervention, but we would really not get distracted from the main purpose of teaching skills. And we would teach to the manual. Now it's a modular skills program. And so these are the things that we can draw on to really help our clients. So we've got mindfulness, which we've talked a little bit about. We've also got their interpersonal effectiveness in the bottom left there. There's a whole series of skills that we teach about how to identify your wants and needs in interpersonal situations, how to ask for what you want and what you need, or to say no to things that you don't want or don't need, how to improve the quality of your relationships, as you're asking for your needs, and how to retain your self-respect. It's a whole suite of interpersonal skills there to really try and help our clients learn to develop those. Then we also have a whole set of skills that are focused around distress tolerance. So the recognition that sometimes there are some situations that you can't change, you can't problem solve, is that actually you simply have to get through without making the situation worse. And there are sort of 2 elements to that. There's a sort of set which are perhaps very familiar to many folk from a mental health background, or people who aren't from a mental health background, but skills that are about crisis survival. So, distraction skills, self-soothing skills, things just to help you get through the moment. Things that you can do when you can't solve the problem at the moment. And then there are also a whole set in the distress tolerance called radical acceptance skills, which have strong connection to mindfulness, which is radically accepting the situation that we're in. And you can only radically accept the present and things that have happened in the past. You can't radically accept the future. But to radically accept how things are at the moment, to let go of the struggle of wishing that things were different than they are. And so the skills in distress tolerance are a real excellent complement to those in mindfulness, and they represent the sort of the acceptance end of the dialectic, if you like. And then we have interpersonal effectiveness, which has also got emotion regulation, which are on the change side, which really focus on how to help clients to change things. And I just wanted to say a little bit more about emotion regulation, because the emotion regulation skills, given the formulation that we talked about what the problem is, that the primary issue is one of emotion dysregulation, it's really important that in the skill set we're really focusing on how to regulate emotion. In order to regulate emotion effectively, it's helpful to have good distress tolerance skills and mindfulness skills. you need something at the heart of it which really helps you regulate your emotion. So one of the central elements in the DBT emotion regulation skill set is, first of all, helping our clients to understand the emotion families. That there are a set of what are often called basic emotions, which all humans experience. Wherever you go in the world, people experience these emotions. Now, emotion theorists disagree a little bit about which precisely are the basic emotions, and some theorists disagree a bit about whether shame and guilt are separate ones or whether they're on a continuum and so on. And those are important theoretical debates. However, from the point of view of our clients, the first thing to say is that there are these emotion families, and there's a lot of agreement about which ones they are. And so I've put the main ones here: anger, fear, sadness, shame, guilt, disgust, joy, envy, jealousy. And the first step that we're wanting to do with our clients is, first of all, help them to learn these different emotions and to be able to label them. There's a lot of research that shows that simply being able to label an emotion accurately helps to regulate it. And often our clients, because of the environment in which they've been raised, haven't really had the experience or the support to be able to discern the different emotions that they experience. And often they just feel like they're experiencing a glut of kind of a ball of emotions that, that they can't really distinguish. I remember one client saying to me, she said, "What do you mean emotion?" She said, "I feel crap or not crap. What else is there?" And in order to kind of really help our clients move, we have to begin to tease out these complex emotional experiences into the distinctive emotion families. Now, each one of these emotion families has a unique signature. So facial and body expressions, so facial and body expressions for anger are different to the facial and body expressions of sadness or joy. Yeah? So these different expressions are unique for each of these different emotion families. And some of these are very powerful. So, for example, disgust, the sort of unique facial feature of disgust is what's called the dimpler flash. So here it is, otherwise known as the Elvis Presley lip move. Yeah. Now, the dimpler flash is an expression of disgust. And actually, one of the kind of a key emotion researcher, John Gottman, who was a marital researcher, did a lot of studies of couples who were in conflict. And what he discovered is that the number of dimpler flashes in the first marital therapy session was a predictor of how likely a couple were to stay together or not. So you can imagine it. One member of the couple says, I really realise that I have not done enough to help you in raising the children, so I really need to do more. And the other member of the couple goes, yeah, right, yeah. So it's an expression of disgust, has a strong association with the relationship breaking up. So we see this, of course, a lot, for example, in our clients who have eating disorder, is that, they look at the food and they have a disgust response. Yeah. And so really important to understand these, because these are the elements that we're going to use to help us change our emotional experiencing. Each emotion family, each emotion has a unique action urge, so that and this is one of the ways that you can help clients discern what emotion they're experiencing at any given moment. So, for example, the urge for anger is to attack. The action urge for sadness is to withdraw, and then also to seek out that which has been lost. There are two action urges with sadness. With fear, the action urge is to run away. With shame, the urge is to hide. For guilt, the action urge is to repair. With disgust, so we've got the dimpler flash, but there's always a sort of half upper body turn. With joy, we want to approach and do more of the thing that's led to joy. With envy, now people often get envy and jealousy mixed up. Envy is when you desire something that someone else has, and more importantly, you think they don't deserve and you do. Yeah. And so envy leads you to destroy what the other person has. When it's unhelpful envy. You can have benign envy, which leads you to, motivates you to search out and become like the person that you envy. But kind of toxic envy is where you want to destroy what the other person has because they don't deserve it, because it should have been yours. And then jealousy is where you fear someone taking away what you have. So, this is my boyfriend, keep your hands off. Yeah. So that knowing these different action urges can help you to help your client to understand which emotions that they're experiencing. Also, different emotions have different temperatures. Some are hot emotions, some are cold. Anger is hot. Fear can be either hot or cold, depending a little bit. Is that if it's sort of apprehension, it's usually hot. But if it's very intense or terror, then it's cold. Different temperatures are relevant, and different voice tones go with different emotions. So it's helpful for clients to understand these unique signatures, not only to help them identify their emotions, but also these are important ways in which you can then learn to manage your emotions. So, for example, we're all familiar with unwarranted fear. If we are afraid of spiders, or if we're afraid of going to parties, we know that the treatment for that is to expose ourselves, is to approach the thing that we're afraid of. So rather than going with the action urge, which is to run away, we have to turn ourselves around and approach. So this principle of going opposite to the action urge of an emotion is one of the things that can help us manage unwarranted emotion. Is that if you go opposite to the emotion, to begin with, of course, if you're afraid of spiders and you start approaching a spider, your fear will go up. But if you keep doing it, if you keep approaching, eventually your fear will go down. If you keep going to parties and actually engage at the party, it's crucial here that you actually have to engage with people at the party, focus on what's happening, check out, is anyone trying to kill me at the party? Then your fear will eventually go down. And the thing is that this is one of the unique things that DBT brings to the field, is that it applies this same principle, and it works with all other emotions. Is if you go opposite to the action urge, when the emotion is unwarranted, then the emotion will go down. Yeah. So, for example, what do I mean by unwarranted? Yeah. So let's say you hear a noise outside your door, and you open the door, and in walks a tiger growling at you. Okay. Now, in this moment, you would have fear, and it would be telling you to do something. Depending on how close it might tell you to stand really still and freeze. Fear might do that. Or if you're far enough to leg it, it'll tell you to run. And the thing is, in that situation, do what your emotion is telling you to do, because the emotion is warranted by the current circumstances. However, if tomorrow, the lion tamer has been and taken away the lion which had escaped from the zoo and all of that sort of thing, and now you hear something outside your door, and now you don't want to go and open your door. Now, your fear is totally understandable, completely, because yesterday there was a lion or a tiger, but today there isn't. So today your fear, whilst understandable, is unwarranted. And what you need to do is to approach and engage with the environment. And so this is a really important distinction, because often what I find therapists do is that they forget that they major on the understandability of the emotion, which I definitely want them to do, but they forget to challenge the unwarranted nature of the emotion. And that's really what we have to do also, dialectically. Both are true. And if we're going to have the client have the experience of their emotions go down, we have to get them to go opposite in all of the different domains. So opposite in their facial and body expressions, in their action urges, also change their body temperature, change their voice tone. You change their muscle tone. If you want someone to regulate their anger, we saw that in the video, you want them to let go of the tension in their body. But if they're very sad and their body is like this, you want them actually to tense up and to kind of change their muscle tone. You really want everyone to go opposite in every domain of the emotional signature. Now, if we were in a room, I would have you do an exercise to help you have the experience of this. And we can't do this, but I'm going to tell you what it is. And maybe after this talk is over, you might be willing to try it out with a willing member of your household. Yeah. So what I'd like you to do, if you're willing afterwards, is to set it up with your member of your household. So I just want to try something out with you. And what you have to do as the two of you is you have to greet each other as if you were long lost friends. Imagine you had been the best of friends when you were at school together and you've not seen each other for 10 years. And suddenly you're seeing each other. And I want you to greet each other as if you've just met each other after 10 years. This is your best friend, okay? And you need to throw yourself in. When you've done that, you only need to do it for like a few seconds, yeah? I then want you to try to do exactly the same thing again, but without moving your eyebrows. Don't let your eyebrows move. Because in fact, the eyebrow flash, this, is the universal signal of greeting associated with joy, yeah? And so I want you to try that out, and you'll have this experience. If you try and greet without lifting your eyebrows, you will notice several things. Yeah. But one of the things you'll notice, I'm not going to give it away, but one of the things you'll notice is that your joy emotion will not be as high. You notice other things. Pay attention to your voice, pay attention to your body. That's one of the things that you'll notice. And you might think to yourself, well, like, okay, this is a bit interesting, all right, a bit of fun, da-da-da-da-da. But why would you ever want to need that? Well, I had a client who was trying to give up drugs. Whenever she saw her drug dealer, because for her, drugs were associated with joy, when she saw her drug dealer, she experienced joy. In order for her to stop using, we had to decrease the joy that she experienced on seeing him around. Now, we did everything to make sure she was less likely to see him, but the thing was, if she saw him, joy, that led to other things, chatting, and before she knew it, she was buying drugs. So these are the elements of really understanding and acting opposite to emotions. And this is a really central part of DBT, helping our clients understand their emotions, recognizes that they are understandable and it makes sense, and to help them go opposite when the emotion is unwarranted, to get the emotion down or the intensity of it down. But of course, dialectically, emotions also are often telling you something. Yeah. My client who experienced joy when she saw her drug dealer, it was telling her that, she had little joy in her life except in association with drugs. And so we can get her to act opposite to get the joy down when she sees her drug dealer. But unless we address the problem of trying to cultivate joy elsewhere in her life, we're not really going to get very far. So again, this is another element of being dialectical, is that we're going to work on regulating that element of the emotion or the intensity of that emotion that is unwarranted. And then on the other hand, we're also going to work on problem solving to kind of get the thing into the client's life that the emotion was really driving for. Okay. So changing client skill use is really important. It impacts clinical outcomes. And this is just some data from several studies put together in a paper by Andrade, Naishu, Rizvi, and Linehan. And what it simply shows here is that, people come into skills training with a degree of skills. We've got both the red and the blue line. They've got some skills at the start, which is about halfway up the scale that was used here. The clients in red are the control condition, and over time, there's a bit of skill increase. They're not getting DBT, they're not getting a skills-based treatment. There's a bit of skills increase, although it tends to return back to baseline by the time of the follow-up period, because they are in a therapy as well, just not a skills-based one. But what we see in DBT is that they increase their skills, they increase their skills a lot more than in the other condition, as you would expect, and also that maintains. But what's crucial to know is it's that increase in skills use above baseline which mediates the outcome. So the outcomes in the treatment of decreased suicidality, decreased self-harm are mediated by that increase in skills use. And so it's really important in DBT, or indeed in any treatment, if you're teaching clients skills, to make sure that they really acquire them and you strengthen them and you rehearse them to ensure that they can really deliver what the client needs them to do. And I think that's just a really important point, is that we can sometimes as mental health professionals assume that teaching a client a skill is all that we need to do, when in fact that is the absolute minimum. We really need to strengthen that skill in the client's repertoire, and we need to help them get it to work for them, and then to make sure that it generalizes so that it works outside of the therapy environment. So, we've been relentlessly talking about change. But remember that DBT is dialectical. And so, in addition to all this pushing for change, we also have a strong emphasis on validation. Validation of the client as he or she is in the current moment, validation of their thoughts and their emotions and their actions. Now, validation is something that we see in all psychological treatments. Indeed, some psychological treatments, like Rogerian therapy, are kind of based on a validating stance. The kind of counselling core conditions are about acceptance of the client and validating the client. And so, in one element, there's not a great deal that's new here. You would see this in other psychological treatments. There is a difference in emphasis here, though, so that the lower levels of validation, so sort of staying awake, in other words, of course, literally staying awake. I did once have a colleague who did fall asleep in a therapy session and woke up, and the client had put a post-it on their chest saying, "You should practice your own skills," because he'd literally fallen asleep. But what it really refers to is actually being awake to what you see in the moment, as we saw in the video clip, that when the client practiced the skill, I noticed something happen, and being curious about that and being interested in that. Reflecting back what the client says, of course, important therapeutic skill. Mind reading, sort of anticipating, trying to figure out what the client might be thinking. There's a bit of a caution here with clients with personality disorder, particularly borderline personality disorder, and also with young people, is that some people with those particular difficulties can find mind reading very unsettling, and they don't like people to accurately read their minds. It can feel very unsettling. So that may not work so well for some client groups. So to be awake to that. And then validating the client in terms of their past. So, it makes sense to me that you would feel sad because you've lost a lot of people in your life. Anyone who had lost so many people would feel sad. So we validate in terms of the past. Things that have happened in the client's past will make sense of their present moment. Also, we want to really focus, and this is where DBT has a slight difference in emphasis from some psychological treatments, not by any means all. There's a strong emphasis on validating in terms of the present moment. It makes sense to me that you would react that way. I think I would react like that. And we saw a little bit of that in the video, where I kind of said, I was thinking to myself, actually, just noticing I can't stand, I'm not sure that would work for me. So you're kind of saying, this is the fact that you're finding this hard is a human thing. All humans find this sort of thing difficult. Yeah. And I think this is really important, that, often therapists, mental health professionals, we do a lot of validating in terms of the past. But what that can do is it can just end up with the client feeling pathologized, and also there's nothing they can do about their past. So even though that may well be true that their current reactions are strongly influenced by the past, like all of our reactions are, it's more helpful to focus on those elements of their response which make total sense in the present, but like anyone would respond in that way. So anyone would be sad if someone cancelled a meeting with them. Anyone would be ashamed of themselves if they did something that went against their values. And to really focus on validating in terms of the present, not just in terms of the past. In fact, a major on validating in terms of the present. And then also to be radically genuine. And so there's a strong element in DBT of treating your client just like another human being who's having the same struggles as other human beings have, and not to treat them like a client, to treat them like they can hear the truth and not to pull your punches and just to be direct, you know? And I remember this, but sometimes you notice radical genuineness when it's not there. So I remember listening to a therapy tape of a therapist who, and the client had come in and was in quite a suicidal crisis. And the therapist had said, you know, what set this off? You know, something clearly has happened. And the client said, well, I came home from work and I found my husband in bed with my sister. Okay. And the therapist said, I wonder how that made you feel. Now, here's the thing. I don't want to be judgmental of this therapist, because the therapist was actually panicking because she knew how important the client's marriage was to her. The client had already said she was suicidal, and the therapist was terrified of saying anything that would make the situation worse. So she went for what I would call a standard therapist holding pattern, just said, well, I'm wondering how that made you feel. Now, actually, of course, what happened was that this resulted in an intensification of the client's emotional response, and things became much worse. And so a radically genuine response here, and there'll be as many radically genuine responses as there are people listening to this presentation, but it's what you would say if your best friend or your sister, well, actually, that wouldn't work in this case because you might be the one in the bed with the husband anyway, but if your best friend told you that had happened to them, and I can pretty much guarantee you that none of you, even though some of you might be therapists, would say, I wonder how that made you feel. You would say something like, oh my God, that's a disaster, or I've got no idea, I mean, this is just dreadful, or, you know, what a jerk, or, you know, you'd say anything, or kind of, you know, thank God this is your perfect opportunity to get rid of him. You've hated him for years. You know, you'd say something that would recognize your sort of common humanity in this situation. And there's a strong emphasis in this treatment on being radically genuine in that kind of way. Okay, we're almost up to our time, but I just wanted to kind of just say a couple other things. In terms of being dialectical, you know, this is problem solving on the one hand and validation on the other, as we've got change and acceptance. It's also true for the style. So that on the one hand, a DBT therapist is warm and genuine and compassionate, and will self-disclose about their own experiences, provided those issues are solved and it's in the interest of the client. And on the other hand, they will also be irreverent and a bit confrontational. If the client is heading, is sort of really stuck and is heading on a difficult direction, and your normal warmth and validation isn't being effective, a DBT therapist will move to be irreverent and confrontational. I remember one client of mine was forever threatening to drop out of therapy because she hated the way other people looked at her in skills class. And in fact, this was a problem in other areas of her life. And I understood why it was a problem for her. I knew all of that because of her history, but none of that was very helpful. And so one day I just said to her when she threatened to drop out, I said, it's okay, I've got a solution. We are working on getting you to live like a hermit. It's the only thing. You have to just totally be a recluse. It's the only solution. And of course, she looked at me and she paused, but then she was then able to work on some of the other solutions. So just being a bit irreverent, a bit confrontational, that can certainly kind of shift the dynamic in the relationship and help you pivot back round to be able to work on comprehensive solutions. So, in sum, if you're going to work in a DBT way, you need to structure the treatment environment because you're going to have to deliver multiple modes of treatment. It's not as simple as changing your own practice in the therapy room. You actually need to develop a team, as it says there, to be able to deliver all the multiple modes of treatment. When you're doing the treatment, you need to target it. You need to be focused on the top targets and to work systematically through those targets. You want to comprehensively treat high-risk behaviours and not just assess them. That's one of the things that often I see in modern mental health services. There's a lot of risk assessment and writing up action plans, but there isn't a lot of actually treating the variables that lead up to a client's risky behaviours. You need to really focus on developing client skills. And this doesn't just involve teaching them, it involves strengthening, rehearsal, and really troubleshooting the things that get in the way of skills working for your clients. And in order to do all of that, we really have to promote engagement, and in particular focus on life worth living goals. What are our clients' life worth living goals, and how can we help them reach them as best we can? Okay, so I think that's me. I think we're up to our Q&A. So I'm hoping that Neil's going to do something. He's going to appear, I think.
Thank you very much, Professor Swales. That was an excellent presentation. We've had loads of engagement and loads of questions in the chat as well. So I think I'll just get started and ask you the first question here, okay?
Mm-hmm. Yeah, sure.
Okay, so the first one is from Stella, and she's saying, as anyone or as someone who works with patients with BPD, how do you feel about the way public and pop culture depicts BPD? She feels it's quite stigmatized in popular culture and as a diagnosis for characters in movies or TV shows that are manipulative, evil, crazy antagonists, for example, in Fatal Attraction. Considering that, I imagine patients might get scared or discouraged when they are diagnosed with BPD. Have you noticed that as a problem?
Yeah, no, I think, Stella, you're absolutely right. I think that personality disorder and borderline personality disorder is one of the most stigmatizing diagnoses that a person can ever receive. And I think, the depiction in popular culture does not help. And I think, if anything, we're all listening to this presentation as ambassadors to try and challenge those unhelpful stereotypes wherever we see them, and to really help people that we know in the community to understand that this is about a problem of emotion dysregulation. Now, we can't necessarily persuade Hollywood producers to change how they depict these things, but we can certainly do what we can, the way we talk about people with these problems and the way we try to engage them. And the thing that I always say to clients who come in with this, who might be reluctant, I always do tell them, we would do an assessment to check to see if they met criteria for the diagnosis. But I would always say to them that DBT has proven that if you engage in this treatment and it works for you, and if this treatment doesn't work, there are other treatments for this disorder, that your symptoms will go away. We can remove these symptoms. And if those symptoms go away, if these behaviors aren't there, if the emotions aren't there, you won't have the diagnosis anymore. Yeah. So there's a way of getting rid of it. Yeah. And I think this is one of the things that we know about diagnoses, is that if there are no treatments for them, they're often even more stigmatizing. So I think the more we are able to help people with these diagnoses, the better. And as I say, if we meet, we have to challenge stigma wherever we find it. And it's very hard to do. You're so right.
100%.
Yeah.
Okay. So the next question here is from Charles, and it's in regard to acting opposite to regulate unwarranted emotion. How might that link to Viktor Frankl's paradoxical intention, which is deliberately engaging in neurotic behavior in order to identify and overcome it?
Well, that's a really technical question, and I'm not sure I know enough about Viktor Frankl's paradoxical intention to know what the connection would be. I mean, Viktor Frankl his work did really influence Marsha, but more around the development of radical acceptance, of really accepting the circumstances in which you are, and she read a lot of concentration camp survivors' accounts about how to survive the most appalling situations in terms of trying to understand radical acceptance. And so I guess there is an element there of noticing what emotion you're experiencing in order to be able to accept what's happening in this moment, and then in order to be able to go opposite. But I think it really does embrace this idea of both acceptance and change. However, I will go away and look up Viktor Frankl's paradoxical intention, because I don't know precisely. And so I suspect I might not be answering your question, Charles. And it's just one of those downsides of us being on we could have a bit more of a dialogue and where I could clarify if we were together. But very interesting. Thank you.
No problem. Okay, so the next one's from Amy, and Amy asks, how does the team directly benefit the patient as opposed to just making the therapist feel more supported?
Right, good question, Amy. It's both, really, in the sense that if the therapist is more supported and less tense, anxious, preoccupied, they are able to be more flexible, and that will mean that they will deliver a better therapy for the client. So there's a sort of an indirect benefit through the therapist's mental well-being and in that way. But the other thing that the team offers is the therapist is encouraged to take problems that they're having to the team each week to gather different perspectives. So for example, they might go to team and say, look, I've been working with Susan and her self-harm for the last 4 weeks, and we've tried lots of things, and none of the things that I have tried have really been helpful. So I'd really like to hear different perspectives about what might be going on here. Can you suggest alternate things that I might try? And so you get that benefit too of like lots of different heads on the same problem. So there's a sort of more direct benefit, I would say, there. And then also the other thing is that the client also gets the experience of being treated by a team, in that they'll have their individual therapist, but they'll also have at least one other and sometimes two other therapists in skills class. So they have this sense of there being a team to treat them. And so that means if things are a bit rocky with the individual therapist, they maybe can approach their skills trainer to check out and get some coaching on how to resolve that problem. So there is a more direct benefit. So both indirect and direct benefits, I would say.
Great. Okay, so just following on from that, we've got a question from Dan, and he's asked, in the DBT consult team I'm in, at times there seems to be conflict between those who are more DBT minded and those who are more person-centered and attachment-focused. Do you think there could be any issues with clients being put into DBT skills groups while their one-to-one therapy remains much more attachment and person-centered focused?
Yeah, good question, Dan. I mean, the thing is that there have been some studies that have shown that clients do better if they get the whole of DBT as it is, unadulterated, with everything as it's meant to be in a DBT way. That is for clients who've got the most challenging behaviour. So it depends a little bit who you've got on your DBT program. On the other hand, what I would say, though, is that if you were saying this is a DBT program and the client's coming in for DBT, this is a really important problem to solve, is that if the clients are getting person-centred therapy and not DBT, and the therapy fails, which might not be to do with that, but the therapy could fail anyway, the client is likely to say that DBT didn't work when actually they didn't have DBT. And I actually see that quite a lot. People coming saying, I've had that DBT, it doesn't work. And actually, when they inquire, they actually haven't had the treatment. So it's really important, if you're on a DBT team, everyone has to sign up to deliver DBT when they're doing DBT. Now, that doesn't mean to say that a person-centered approach isn't helpful anywhere else, nor does it mean to say that the person-centered therapists on the team don't have something vital to bring to a dialectical contribution to understanding a client's problem. Yeah, that can be super helpful, that people are coming at it from, they have different ways of thinking about it. But when you're in a DBT team, everyone on that team has to sign up to delivering DBT. So my suggestion would be that you set a little kind of away day for your team, even if it's only for a couple of hours, to really discuss this issue about who is committed to delivering DBT or not. Because if you're going to do it, then you need to do it kind of completely all the way. And then deliver the treatment as it is for the period of time. And then if it's helpful or not helpful, you can then have an honest conversation with your client, and maybe something else would be more helpful. So that would be my suggestion about how to go about that. But your person-centered colleagues have a lot to bring to the team. So it's not about getting rid of them. It's just that when they're on the team, they need to be doing DBT. Yeah.
Okay, thanks very much. The next one's from Dana. And Dana has asked, can a quiet BPD be hard to intercept or hard to diagnose by a classical CBT therapist? Can it be misdiagnosed with something else? There are a lot of similarities of diagnosis between CPTSD and borderline. And she's saying that she speaks as a client and she's not a therapist. Because of her own difficulties, she started to really love psychology, and she finds a lot of descriptions quite vague, general, and not very specific.
Yeah. No, I think that can be really a problem. And was the beginning of the question, was it quiet borderline? Was that what you said, Neil?
A quiet BPD, yeah.
A quiet BPD, yes. Well, interestingly, what Marsha Linehan talked about was that she talked about stage 1 of DBT is dealing with the sort of what we might call out of control behaviours. But then stage 2 is what she called quiet desperation. And this was a stage of treatment, exactly as you're saying, that she felt that was people pay a lot of attention to getting control of those behaviours and then didn't really attend to the quiet desperation that person then might be left in. So in DBT, there's a strong focus on making sure that you then address that. And indeed, there have been some adaptations of DBT for specifically helping clients who have PTSD as a problem, both alongside the DBT and in slightly different ways. But I think your question was also about, the diagnosis. And I think here's the thing, is that DBT doesn't really believe in diagnosis as a thing. It just, unfortunately, in order to get research grants and to study it, that's how you do it, or you used to have to do it. Fortunately, things are now changing. What DBT really works with is the fact that people have had early life experiences, many of which have involved trauma, that have resulted in patterns of behaviour and ways of coping that aren't helping right now. And the treatment is designed to try and address those patterns of behaviour and patterns of coping to try and help a person live a life that they would more want to lead, and that will include treating trauma. So I do think that the difference between, say, BPD and complex PTSD, which is kind of another diagnostic term, I do think complex PTSD is perhaps a kinder term than borderline personality disorder, and potentially could be much less stigmatizing. However, I think the challenge is that not everyone who has the problems for which DBT can help necessarily has trauma. And so it could potentially lose some folks. So I think these are the difficulties. But I totally agree with you. And Marsha Linehan herself, she wanted to really address that quiet desperation. It is real desperation for people with those difficulties. Yeah.
100%. So Juliet now has asked, has DBT been used for psychosis? And if so, does application differ from when it is used for BPD?
Yeah, good question. Juliet, I think there isn't a randomized controlled trial which has compared DBT for psychosis with other sorts of treatments. And so at that level, we don't know. And in fact, many of the treatment trials excluded people who had a diagnosis of schizophrenia. Because, the worry was particularly that it might be very destabilizing to do even the brief mindfulness practices that we do. However, over time, many clients who come into DBT trials may not meet diagnostic criteria for schizophrenia, but they may well have psychotic symptoms. And certainly in routine clinical practice, a lot of clients who come in to treatment programs have psychotic symptoms. And so you can treat those symptoms in DBT, and I've done so myself. We simply list them out under that quality of life interfering list that, is a diagnosis of psychosis, and we would list out, whether it's auditory hallucinations or paranoid delusions or whatever they are, and we track them on the diary card, and we would behaviourally analyse them in the same way that we would any other behaviour. And we'd be looking, and I think particularly with psychotic symptoms, you're often looking for things that happen before, sort of on the antecedent end. Often intense emotion is a controlling variable for those sort of experiences. And so we would work on applying skills in much the same way. Of course, often there are other medication interventions that can be helpful alongside, and also other CBT interventions for psychotic symptoms as well. So we don't have a lot of data, but certainly if a client meets criteria for DBT, but also has some psychotic symptoms alongside, we would definitely treat those within the context of the treatment program. Yeah.
Thanks. And the next one's from Lisa. Lisa says, I can see that some of this way of working can be part of individual therapy. What is the difference between working individually with supervision and peer group supervision and working with a team?
Well, I think the thing is that if you are working with a client individually with supervision, I mean, that's important for any psychological treatment, it's still not the same as a team focus, particularly with the dialect. You know, if you've only got two of you, yourself and your supervisor and the client, you can't really resolve dialectics effectively. What you really want from the team is multiple different perspectives. Now, there are some circumstances in which it's really difficult to run a team. I know that people have, for example, in private practice, you know, perhaps one or two therapists together have put together a small DBT team and worked that way. And I think if that's the best that you can do, that might be the best that you can do. And at the same time, I think it's important to know that the evidence base has always been for a team of people delivering the treatment. And so we just have to be a bit cautious. So if you're doing it in a different way, the thing to do is to track the outcomes of your clients, be sure that they're getting good outcomes, just as a check for that. I think there's just a different spirit somehow working on a team. It's a different kind of feeling working together as a team. But I mean, I actually meant to say this in response to someone else who asked a team question earlier, is that we don't know a great deal about the precise impact of the team on clinical outcomes. Or one of my PhD students actually has just been starting to do some research on that. So we'll see if we can try and answer that question, because it is an important question. You know, this is a complex treatment. We know that skills are relevant in outcomes, but we don't actually know for sure that teams are relevant in outcomes. And so we await further data on that point.
Cool. Okay. The next one is from Roland. Has DBT been used for adults with autism spectrum disorder?
Yeah, good question. There have been some initial sort of small studies looking at that, and there's been a lot of interest in it. But again, it's just a new sort of area. And so to be able to say systematically that it definitely is helpful for that is not clear. I think also one of the other things to say is that in some areas, there's been, you know, that DBT is really targeted for people who have very strong emotions and difficulty controlling their behaviours and often are quite impulsive. And another researcher in DBT called Tom Lynch has been much more interested in people who may well have a lot of intense emotion, but actually are not impulsive at all, are actually more planful, more organised, and more attentive to detail, we might say. And he's characterised people with those sorts of presentations as being more over-controlled rather than as DBT as it currently is for people who he would say, well, perhaps more under-controlled. And so he's been doing a little bit of work looking at that and thinking about people who might be on the autistic spectrum to see if his slightly different set of skills, which are more about becoming more open and less controlled. So not thinking so much about controlling emotion, but thinking much more about social connectedness might be more helpful. So again, I think we're just beginning early stages to really look at what's really helpful for people who have those sorts of difficulties. Yeah.
Fantastic. So just before you go, Michaela, for anybody listening to this that is interested in training in this approach, where can they find information about that? Are there any books or resources that you would recommend as well as a follow-on from this?
Yeah, sure. So in terms of books, I mean, I always feel a bit uncomfortable about this, but if you're a beginner, the book that I wrote with Heidi Hurd called Distinctive Features of DBT was designed just as that as an introductory text. It's very brief and it gives you a good introduction. For those of you who are interested in what I was saying about emotions, I can strongly recommend this book by Christine Dunkley called Regulating Emotions the DBT Way. That gives you a lot of practical examples of how you can use the DBT emotion focus in whatever therapy you're doing. So I think there are some good books there on kind of sort of getting you sort of started. If you've done introductory work on DBT before, then obviously the DBT skills manual. In terms of training, I think it depends a little bit how much training you want. There are lots of opportunities where you can do skills training workshops where you can learn how to do the skills. But then if you wanted to learn to be a DBT therapist, that would be a much bigger journey of kind of a more intensive set of training. And there are different companies, obviously I have a connection to one, so it would be inappropriate for me to recommend any particular company for training, because there are other companies that offer training in this treatment.
No problem. Okay. Well, Michaela, it's been an absolutely fantastic presentation. The feedback we're getting in the chat is really, really positive. So well done. I hope you enjoy the rest of your Sunday. And
thank you very much. Yeah, and it was great to have you all here. Thank you for joining. Okay. Bye-bye.